We're very pleased to have Dr. Craig Peters, who's really been a wonderful supporter of fetal imaging for really your career, Boston now here, and we're going to be talking. He's going to be talking about the implications of fetal pyelectasis. This is something that we see virtually daily. Always question: are we overcalling, undercalling? So I think we're going to have some great insight to what fetal pyelectasis really should be about, and when we should talk about it, and when we don't need to. So thank you, Craig, for coming. And for those who are listening, just please mute your phones because we can hear some of you. So just mute it, and you'll be able to hear Dr. Peters.
And then they can unmute when the question.
Right, and at the end of our presentation, we'll have time for Q&A, and then you can unmute your microphones. Okay, thank you.
And I assume everybody can hear me online, but since you're muted, you can't reply. So, I mean, everyone here is interested and conversant in fetal diagnosis. I've had the privilege of sort of growing up with this in my professional career, and remember as a medical student with Roger Saunders, first being able to say, that's the placenta and that's the head. I felt I had accomplished something at that point. And we've obviously come a long way since then. And now we are looking at 3D renderings of children's anatomy and looking at far more sophisticated diagnosis. But it always is interesting to look back in history, and in some ways this is one of the first prenatal diagnoses, and that is the Virgin Mary recognizing that her child is special, as I think most mothers feel. And you can see a certain look of anxiety and uncertainty on her face in this wonderful old fresco. We've come a long way from there, and this is a cartoon I always liked. This is 32 years ago, geez. And talking about the potential precision of fetal diagnosis and predicting the hair color and an aptitude for math and whether they have this congenital anomaly of being a Red Sox fan. So what I wanted to focus on at Dorothy's request, and I think this is actually a really good topic because it is huge numbers relative to fetal diagnosis and uncertain impact. And that's when you look at risk, which is frequency and impact, it's a high impact, high risk thing because we're not sure how to draw the line. And that's been our challenge now for really over 30 years in terms of figuring out who we need to worry about. And so these are large numbers of fetuses and infants with mild to moderate degrees of renal dilation. The challenge is that the risks are sporadic and what I think I've come to call stochastic, in that they have a random probability distribution or pattern. You can analyze it statistically, but you can't predict it precisely, and you have a hard time predicting it for an individual. Whether a child with reflux is going to get an infection is, to some degree, stochastic and unpredictable, even though we can precisely predict it for a population. And that's been our challenge, because and how you perceive that difference, I think, is the basis for why we have controversy on this. Because some people, again, see a glass half full or half empty. And I think how you perceive these risks is important in making clinical decisions. And that's been our problem for the individual patient, who is really who we're taking care of. Reports of outcomes of prenatally detected hydronephrosis, they're based on definitions of obstruction or clinically significant. We see those terms all the time in the paper. Have to be interpreted very, very carefully, because if you're not conversant with pediatric urology, nephrology, you sort of take this for granted. But once you start learning, well, how did they define obstruction, or what is clinically significant, it's all over the place. And we continue to argue in our community, nephrourology, as to what obstruction is. And it's not a black and white thing. It's a continuum. It's a spectrum. And clinically significant might be the fact that somebody had to have some imaging tests, but has no further consequence, or someone who had to have surgery or actually ended up with renal failure or insufficiency. So how these things are defined are very important, and that's part of the challenge of interpreting our literature. So pyelectasis really is just dilation of the renal pelvis. It is not dilation of the calyces. But I really think from a practical standpoint, we should be talking about dilation of the renal pelvis and mild dilation of some of the calyces. They're not blown out. In the most commonly used grading system, the Society for Fetal Urology, this would be a grade 1 and 2. Now, I don't like the SFU system. I've never liked it. I was involved in the early papers and I was a charter member of the SFU. And I never liked this scoring system. I still don't like it. We're trying to come up with something better, but that's what's out there. Similarly, AP diameters alone of the renal pelvis are imprecise and not always correlated. You can have severe intrarenal hydronephrosis with a relatively small pelvis because it's intrarenal and not extrarenal. That is a very different thing than a 7-millimeter pelvis near term. So you have to look at what these scores tell you and how to interpret them as well. And that's why, this definition I think is a little bit mushy. But I lump grade 1 and 2 pretty much together, mild to mild moderate hydronephrosis, whatever that means. This is mild, and some would call this just pyelectasis. There's no real calyceal dilation. Here you start seeing a little more calyceal dilation up here, but it's just typically in the polar areas. And then this, too, is very mild dilation with the two little eyes of the upside-down seal. That takes some imagination. And then, of course, this is severe, and I think I have a showing of all of them. And you're all familiar with this, but again, it's how we convey these degrees of dilation that are important. This is the SFU system along with a number of others that we use, and this is pretty much what we're looking at. So to me, what we're talking about today is SFU 1 and 2, so you can have some calyectasis, but it's not this sort of diffuse calyectasis that you see with grade 3 or the variations in grade 4. And part of the problem with the SFU system is 3 and 4 are lumped together, and there's huge difference functionally and clinically between, a low grade 3 to a grade 4. And we have no great system for measuring these. That's one of our research projects, actually. And then your AP diameter typically is going to be around 1 centimeter or 10 millimeters up to maybe 1.5. Now, many people would consider 1.5 way over the threshold of concern, but I'm not sure that it is, and that's what we'll look at. This is from a registry we started in Boston. They've added more patients, but this just gives you a distribution of the numbers of kids, and these are referred in. So this is not a fetal diagnosis group. This is a postnatal group in terms of dilation. UPJ being mild and moderate is the vast bulk of these patients, and then you have a few severe ones, but most of these are mild, moderate, which is the group we're talking about. Looking at sex distribution is a male to female ratio of over 4 to 1. Some people go up to 7 to 1, and it's consistent through these the mild to mild moderate types of grades. So it's most commonly in males. It resolves frequently, and this is well documented within 1 to 2 years. And so when we think about what is this, because this is not I don't think a fixed obstruction by any means. It's dynamic. What processes are also changing? And is it maturation of the ureter, of the ureteropelvic junction, or could it be downstream? Bladder, urethra, something like that. So what we've looked at in trying to answer this question, because I think it's important to understand what's going on, is what might be causing this. There's lots of theories of severe UPJ obstruction, muscular maldevelopment, neuronal issues, a variety of other things, none of which are very useful clinically. But I think some insight comes from the fact that this is the kid who has typical mild, moderate hydro, and it's the little boy. And boys, as any of you who are parents or work in the NICU know, pee at a whole lot higher pressure than little girls. And it's, I think this may be part of it. When we look at voiding dynamics in neonatal males, and this is our work in the fetal sheep and newborn lamb, and then this is in humans. And what we see in a fairly large number of kids, and almost all of the animals, is it's what I think you could call an immature coordination between the bladder and the sphincter. So that normally, as the bladder contracts, you have a coordinated response. The sphincter, which is the pelvic floor, relaxes, lets the urine out at low pressure. What you see in the immature animal is almost a phasic contraction of the external sphincter that creates intermittent spikes in pressure. And we see this in neurogenic bladders, kids with spina bifida or certain spinal abnormalities, and we call it detrusor sphincter dyssynergy. You can see this in normal kids, and I think that to some degree it's a maturational process. This has been shown, a good friend of mine in San Francisco showed this in fetal lambs, which is a little harder to do. We saw it in our neonates, and interestingly, in our patients or lambs where we created reflux, those who had more dyssynergy had higher grades of reflux, but it ultimately resolved on its own. And we weren't doing anything, and they were just simply maturing. So I suspect that this is a reflection of some degree of immaturity. I think all boys have it to a degree. We're probably looking at your outer 5%, as in any biological bell curve. And some have it more extremely than others, and they are going to have higher grades of reflux, potentially higher grades of hydronephrosis.
Can I ask you just real quick,
Yeah.
do you think that that immaturity is muscular, or do you think it's autonomic?
Oh, I think it's autonomic. And part of that is, because to me, one of the great paradoxes in pelvic function is, how does the baby know in utero to pee but not to poop? Then suddenly at birth has to learn how to poop. Because if they don't, they're in trouble. You look at animals, cats and a number of other vertebrate animals, they do not void spontaneously. The maternal cat has to lick the perineum of a kitten to stimulate voiding. It has to trigger it through some sort of a reflex action. You know, they manage, obviously. Sheep don't do that, but maybe it's just part of the spectrum. So I think it's autonomic, without a doubt. And there are a few ideas about what some of the mediators are, but we don't know enough about that yet.
Is that the reason that we may see a contribution with Down syndrome babies because of autonomic changes?
Well, I don't know a lot about that, but very clearly I have seen a handful of kids with Downs, and it is documented in the urological literature that they have idiopathic bladder dysfunction, and it's typically a dyssynergic pattern. I learned this with a kid in Boston. I had to end up, he was getting hydronephrosis, and it does feed into this. He had no overt spinal lesion or anything like that, but he was having bladder distension, urinary retention, and hydronephrosis, like a kid with spina bifida.
Interesting.
The other thing that we observed, and this was purely an accident, and I love accidents in research, is that when we were looking at animals, our fetal sheep models, where we were looking at obstruction and reflux, if we simply close the urachus off in a male animal and don't do anything else, that animal develops hydronephrosis in utero. Didn't touch the bladder outlet. In a female, didn't touch it. In a female, if we put then a partial obstruction around the urethra and close the urachus, they got hydronephrosis. But we were initially using these animals as controls. When we were creating bladder outlet obstruction to mimic valves, we clipped the urachus, and they were the controls. And we realized all of a sudden, wait a minute, they don't look normal. So clearly, the male and the female and the sheep, and I think it's a high-level mammal, has some parallel, and these are mild to moderate degrees of hydronephrosis. We didn't deliver these animals and keep them alive to see if it resolved, but I think just like our reflux model, they probably would. So it tells us that the male animal, through normal development, has a higher pressure, lower urinary tract that is maturationally dynamic and will cause mild to moderate degrees of hydronephrosis that will resolve spontaneously. So I feel fairly strongly through this inferential evidence that that is the basis for this wide spectrum of mild to moderate hydronephrosis in human males. And since the sheep are not humans, I realize, but I think there's a fair amount of similarity. So when we think about this, then what are we worrying about? Because, you know, there's got to be a basis. Two things, obstruction and reflux. Now, with regard to obstruction, the severity of the hydronephrosis is roughly proportional to severity of obstruction. Now, it's not a direct correlation, but, you know, if you've got mild dilation, it's not severely obstructed. And at most, these kidneys with mild to moderate dilation are very mildly obstructed. And in those cases, we're pretty confident, especially since it resolves, that it's not going to hurt the kidneys in any significant way from obstruction. Because we know that even with severe dilation, function can be preserved, these can spontaneously resolve, and we clearly need to evaluate them, but in this group of patients, I don't think it's as severe a concern. Reflux, though, is of more concern. There's a significant incidence. However, we don't know what the real risk is, because reflux per se is not necessarily bad, but it can be associated with bad things. So a number of studies have looked at trying to correlate predictors from prenatal dilation into postnatal. This is a study by Rich Lee up in Boston. There was a meta-analysis of a large number of these studies and looked at a variety of factors. The problem with this is, of course, they're stuck with the individual report's definition of clinically significant or obstructed. And so take this with a grain of salt. But fundamentally what they saw is a relatively rough correlation that with increasing AP diameter, there was a higher positive predictive value of clinically significant, needing imaging, needing antibiotics, needing surgery. Or you could easily fill in for needing is getting, and that's part of our problem. Some of this is self-fulfilling prophecy, because we've always evaluated them. Well, let's keep evaluating them without not really necessarily knowing the outcomes. So rough correlation there. When they looked at the specific postnatal outcomes, it was clear that the UPJ, so the obstructive process, is more directly correlated with severity, whereas, importantly, reflux is roughly the same no matter what the severity. So severity of dilation is not a great predictor of the likelihood of reflux, and that's part of our problem. A number of studies have looked at using AP diameters for clinical prediction. This is one relatively recent that they use the cutoffs here of greater than 4 millimeters at 20 weeks, and then at 20 weeks, these kids all had ultrasounds, and then postnatal ultrasounds at 1, 6, and 12 months, and an AP diameter greater than 15 millimeter or poor parenchyma had MAG3 function, had MAG3 studies for function, and a T-HAFA was done and a VCUG was done. Very high male preponderance in this population. Relatively few, very few, ended up having surgery in the pyelectasis group, 3 out of 149, and 5 out of 41 with hydronephrosis. I would propose that probably even that was a little more than we would do here, in that their surgical indications were relatively arbitrary, and none of them were assessed for deterioration. So that's, again, your indications for surgery are going to very much define your outcomes, and we still argue about that constantly. And they put no consideration for monitoring postnatal change, and I think that's very important in monitoring these kids, and that's why I think it's useful to use ultrasound to monitor, and particularly for the rare kid who may progress. Very uncommon, but it does occur. In terms of if you do more invasive functional imaging, and this is diuretic renography, MAG3, kidney scan. This was our Boston group where we just did the mild moderates and separated them out. Fundamentally, they have normal function, and generally their washout times are very fast. A few of them high, and that may be artifactual. This test is not easily reproduced. They do it very, very well here. Masood Maj is sort of the guru of this, but from outside studies, you have to be a little careful. Boston had a very good team here. So I'm confident that these kids have really minimal risk of worrisome obstructive parameters. They resolve. And it is somewhat related to the severity. Mild resolves faster than moderate and mild moderate. And I think it's important to realize sort of what the half times for resolution are for counseling these patients, and that's sort of what we do. And to just tell the parents, don't worry about this, these are going to do fine, but we do want to monitor. It's rare that they get worse, it does happen. So from an obstruction standpoint, we really don't recommend functional imaging anymore. I don't think there's much value. You might want to use prophylaxis, but there's absolutely no clinical data to support it. Certainly if a kid gets a UTI, you want to pay attention, but I think their risk is low. And then after an initial scan, and I mean a renal ultrasound scan, before 3 months, we do subsequent scans can be spread out. I like to demonstrate resolution, but again, that's hard to prove. However, when we do evaluation, VCUGs show a significant reflux. And this is one series, and this is from our Boston group, where given hydronephrosis severity, see the incidence ranging from 20 to 30. The higher grades may be a bit artifactual in terms of there being more selection bias in those. But when we look at the mild to moderate, you're looking hovering between 20, 25, 30% chance of reflux with a wide distribution of grade. Other studies have shown no prediction value for the severity of hydronephrosis. So you can't use that as a cutoff. Now, when we think about screening, and this is doing a VCUG, and the concern that everybody raises, well, it's slightly invasive, but more importantly, it may find reflux that you don't care about. Not all reflux causes trouble, and that's what has been the pushback to say, we don't need to study these kids. Let's not find it. So the benefits would be you identify, in theory, those patients with reflux before they have an infection and damage their kidney. The burden of screening, though, is you may identify patients with low-grade reflux with little risk of renal injury, and therefore we're over-testing.
And low-grade, you mean 2?
2, 3, yeah. Now, everybody has a difference. I mean, if you live in Sweden, they don't even treat grade 2 reflux, even if they presented with UTI. Not sure I buy that, but. And there are a variety of studies that have shown incidences ranging from 17 to 38% of reflux in this population. In our group, we had an incidence of 26%, and this is mild to moderate hydronephrosis only, and no specific clinical predictors could exclude it. This was our meta-analysis in our guideline study for reflux in terms of whether we should screen these kids. Mean incidence 16.2%. Okay, fine. What do you do with that nice, precise number? You know, we do see a slightly higher incidence in females, and higher grades of reflux are certainly correlated with renal cortical abnormalities, so you don't want to ignore them, but trying to pick them out is difficult. And you can see from the spread in the literature that it is a bit all over the board, and I think that has to do with most of these are relatively small studies. So is this clinically important reflux? One study by Elizabeth Yerkes was 15% incidence. 16 patients of a similar degree of hydronephrosis didn't undergo VCUG, none had a UTI, small numbers. Bigger study from England by Morphy, similar sort of finding. They had a cohort that they followed, mild to moderate dilation, never got VCUGs, and only 3 came back from in follow-up over at least a year with a UTI. So clinically, it doesn't seem to be too worrisome. Ismaili's study, similar sort of pattern, showed relatively lower incidence and pretty good resolution. So in Boston, for many years, we thought these kids were doing fine. We stopped doing VCUGs in mild to moderate groups after a paper we published in 92 or 93. So they weren't screened, and we assumed they were doing well, but we thought, well, let's look at them. Here's sort of a natural experiment. So we had almost 1,500 kids with mild to moderate hydronephrosis. VCUG was done in 1,100, and that was due to individual physician preference and stuff like that. And we found 26% with reflux, as we mentioned. No VCUG was done in 340 some odd kids with mild to moderate hydro. In theory, based on the 26% incidence, there would have been 91 patients who had reflux that was not detected and therefore not treated. Those were the kids we looked at, and they were just simply followed with ultrasound and no prophylactic antibiotics. And what we found is they clearly had a higher incidence of subsequent UTI, 13%, and equivalent to 38.4 times 10 to the minus 4 UTIs per patient month, significantly higher than the group that had VCUGs and had been found to, have reflux and were treated. So not only does it suggest that there's a risk, but it also suggests that treatment has a benefit. Now, when we published this, we got this editorial response from my good friend Paul McGurrian, now in Seattle, that the conclusions were made through the lens of the provider. Now, he's sort of advocating for the healthcare consumer, who he lists as government, insurance, and patient advocacy groups. I don't know where the patient and their family falls in, because a lot of the parents, when you discuss this, especially if they have an experience with a kid with a febrile UTI, lean towards screening. And this is our problem, is who gets to make this decision and who's going to pay for it. I agree that the number, when you look at the treatment effect, if you will, isn't terribly high, but it's not trivial, and it certainly is well above the 0.05% of that potential group. Now, he sort of talks about the need for randomized trials. Unfortunately, I don't think that's going to help us, because we're still going to come down to the issue of how do we value it and how do we compare those risks and how do we weight them. And that's our frustration right now.
Was your group scattered for male-female?
No, it was heavily predominantly male.
Predominantly
yeah.
male.
And certainly we saw more in the uncircumcised boys.
Mm-hmm.
But we didn't have good data on all of that because it wasn't kept. Now, I think we clearly could do a good prospective study, but it's still going to come down to similar numbers, and then how are you going to weight them? Is it worth the risk? And, when I wrote that article, we pretty much used it to say, this is not to advocate VCUG in everybody, but to be able to give the parents information with which they can hopefully make a decision. Recent report from here by Nora Lee that we published, and we tried to better refine who we do a VCUG on, and we could certainly limit it in up to 63%. However, we had a miss rate of about 17 or 18%, I think. Is that going to be clinically significant? We didn't see that, but again, these kids were on prophylaxis, so we didn't truly do that experiment. Another study, I'm blocking where they came from, had an algorithm to reduce the numbers of VCUGs, and they really looked at AP diameter and grade 3 and 4, which we know is a more severe group. So in screening for reflux, grade of the hydro is not predictive, and I think that's an important take-home message. The incidence is between 15 and 20% in all patients, including those with resolved hydronephrosis, and that was Zarin's paper from way back in the late 80s. There's no clear evidence to support or avoid postnatal imaging for reflux in the context of mild to moderate fetal hydronephrosis. If you have severe hydronephrosis, yes, you need to do it. If no VCUG is done, then I think you need to inform the parents of the risk of reflux and UTI, clinical signs and symptoms, and make sure they have access to care. And I think in that case, you'll probably do some benefit. So I think VCUG can be considered for all patients with some prenatal hydronephrosis to minimize risk of renal damage. One infection can do a fair amount of damage, and that's the problem, especially in an infant. And urosepsis is not good for newborns. But you have to also believe that treatment can prevent renal injury, and that's never been truly proven. That's a whole other discussion. But we can prevent infections, I think. So if VCUG is to be performed, certainly we would recommend starting the kid on prophylactic antibiotics until you do the testing. If you're not going to do the VCUG, then it's an option. But doing your postnatal ultrasound to define whether to do a VCUG doesn't make any sense. You're doing the VCUG based on what you saw prenatal. And if there was hydronephrosis, you can bet that there's going to be a 17 to 20% incidence of reflux. What we can't tell you is whether that's going to be important. So it's like Calvin and Hobbes. The more you know, the harder it is to take decisive action. Once you become informed, you start seeing complexities and shades of gray. It's realize that nothing is as clear and simple as it first appears. Ultimately, knowledge is paralyzing. So being a surgeon, I can't afford to take that risk. So, quick run through it. So I don't think it solves it, but I think it, and to me, I've come to realize in almost everything we do, if you have some data, you can have an intelligent conversation with the parents. It's very easy to convince the parents of whatever you want, but I don't think that's ultimately beneficial in the long run.
Do parents consider giving antibiotics a burden?
Yes.
Okay. So that's an anxiety then for them.
Yeah.
And the other
it is not a burden operationally. It's everybody's worried about antibiotics now.
correct.
And I think
yes.
not unjustifiably.
Yeah, are there
Not
any
know.
evidence to say these kids are more vulnerable or to resistance?
No. So there's actually two very good studies now, big studies, one from Australia, one from here at NIH, looked at prophylactic antibiotics in kids up to age 4 or 5. Yes, if they get a breakthrough UTI, it's going to be resistant to what they were taking. That's definition almost. But they did not have a higher incidence of difficult-to-treat clinical problems, actually had a reduction in the number of non-urinary tract infections, ears, skin.
Don't say that.
No, we don't push that. But it
makes sense.
Right.
Yeah.
Well, I've had some parents, we've had them on antibiotics and reflux is gone. I said, well, we can take them off. They said, wait until RSV season's over.
What about incidence of gastrointestinal problems? Do they have a higher incidence?
We have not seen it clinically. And in the RIVER study, which is this big NIH study on prophylactic antibiotics for reflux, 600 kids, randomized, prospective, double-blind, placebo, there was not an extra incidence. Now, if you look at stool cultures, there were more resistant bugs in the treated group. Fine. Recent paper we just circulated, they looked at the microbiome of kids on macrodam, not Bactrim. No significant change over time.
How can that be?
Well, they saw transient changes, but they didn't cause any clinical problems, and then when they went off the antibiotics, it seemed to resolve. I have to check that study. But I'm not willing to say that it's perfectly safe. We don't know yet. There's some interesting studies in mice. You change their microbiome in their gut, and you can move them between obesity and non-obesity. So we don't know.
And risk for glucose malabsorption and things like that.
And probably celiac and all sorts of other things. We don't know. So
Karen Nelson says all that sepsis work up in the NICU increased risk of CP when they randomized to just new antibiotics and watch versus antibiotics.
Increased risk of cerebral palsy?
I don't know.
that may
Like
be
a
one
bias
of those true and unrelated, but
out of large, I don't know. There's one study that
randomized to just wash versus treat.
Because right now it's just empiric. You start and get the cultures and you put them on antibiotics.
Is there anyone who's listening that has a question? You can unmute if you have any questions.
You have to unmute them.
We have to unmute?
we do it.
Oh, thank you.
Does anyone know how to do that?
I'm coming to you. There should be a
No, it's on. No question.
No, wait, hang on. Let's make sure.
So somebody's speaking. In general, like I'm looking at the different MFM groups around
Sorry,
the
we're going to
city.
see if we can unmute you.
Looking at different MFM groups around the city, I feel like people have different thresholds to refer into, for a prenatal consult. What kind of are there any recommendations, anything? Obviously, if we see severe dilation, they're all going to be there, but I've seen people refer to very mild positive versus others.
Well, the question is reasonable thresholds for referral prenatally. I think part of it depends if you're, as an MFM, if you're comfortable counseling about this and preparing and then helping guide the family into appropriate postnatal follow-up, which for a mild degree would be simply a postnatal ultrasound, and then the discussion, and that discussion should probably be more urology, nephrology than you guys, and make the decision whether to do a VCUG based on this degree of uncertainty. Then, have that discussion and then make the referral postnatally. There's nothing you're going to have to do right away. The ones we would worry about would be male bilateral hydronephrosis, solitary kidney significant hydronephrosis, and ambiguous appearance. If you can't really tell, is this an ugly kidney or is it just a little bit of hydronephrosis, can't see the kidney very well or something like that, be happy to look. mostly what we're going to provide is changing the timing of your postnatal evaluation. Worst case is the one we've discussed is a missed case of posterior urethral valves. Those kids can come in sick. And we've had a few because it's hard to define and a clear, accurate, data-based threshold. And so do we overtest everybody or do we accept a certain risk? You know, it's a problem here because we deliver at so many different facilities. And
there is the decision about antibiotics, so that is the one.
Right. So, but that
decision. Who's going to make that decision?
Right.
How?
So if you're not going to make it, and thanks for, I was thinking about that, missed it though, is if you're not going to make that decision and you want to leave it appropriately to the postnatal, either urologist, nephrologist, then just put the kid on antibiotics. For 2 weeks, 3 weeks, it's not going to hurt them. That I don't worry about. But it does cover them. Because I've been burned a few times of kids who we identified, we were going to work them up, they didn't get antibiotics for some reason, got sick. You know, I wouldn't get into the, you know, you may get the question from parents of a prospective male child, should we have them circumcised? If they're not inclined to, I don't push it, but clearly that puts them at a slightly higher risk of an infection. And so if they're sitting on the fence and we clearly have something going on, just do it, and it's over with.
And the timing of a circumcision, is that?
Just whenever they can get it done. They're having more and more trouble getting them done. So we're just getting flooded with newborns wanting newborn circumcisions. We do them on our clinic, but we do a big volume. And
is that because
more and more.
pediatricians can't do them anymore? Or?
Well, around here, few pediatricians do it. It's really the obstetricians who are doing it, and a lot of them are pushing back.
I think they trust you.
No, I don't think that.
Really
no.
It's not that. Like, right.
Yeah.
I know,
but but we do see the occasional one that has to be redone.
Yeah.
And there is a quality control issue, which I don't know how to influence that. But no, we're seeing a lot of either the hospital says we're not doing them, or someone came up with an excuse. And I don't blame you. I don't know why obstetricians started doing them anyway. You don't get paid. There's nothing but risk, and you know it doesn't challenge you in any way, unless you have a problem.
We've had a couple I've seen that have come to the ER here post-circumcision 24 hours later with inability to void. That can be an issue too. You think it's a benign procedure, but I don't know if it's the swelling or what.
Or pain. I remember seeing one long ago at Hopkins who came in. He had his little dressing on. He was a ritual cert. Bilateral severe hydronephrosis. This kid had valves to beat the band. Took his dressing off, all my way.
Oh.
Tight dressing.
Nice cure.
Yeah.
You want to just ask folks out there?
Yeah, so is there anyone else who has questions from those listening outside children?
No, it's just, I think it's.
Okay, well, thank you so much. That was fabulous, and it's a confusing topic, but I think the basic thing as a radiologist is just remember ultrasound cannot assess for reflux.
Right.
So we're trying to assess for reflux prenatally by ultrasound and postnatally by ultrasound, and it just doesn't work.
We used to think that there would be a correlation.
Yeah.
The higher the grade, the more likely the reflux. Doesn't work. And I think that's pretty clear.
Thank you so much.
Sure.
Thank you.
Thank you.
Thank you.
Oh, thank you, sir.
Does obstruction cause injury?
Long-term, high pressure.
Yeah, clearly. I think the issue, the question is at what level does it cause it? And what's the relationship? Is it that if you have a moderate degree of obstruction over twice as long, that it causes the same damage as more severe obstruction over half as long?
But if that's true, then in utero drainage may help.
Oh, I think in select cases it can. I mean, we know obstruction can cause changes in renal development, and that's my whole obstruction.
But I thought it was very early in the first and second trimester.
No.
So
It'll
think,
continue.
okay.
Well, we know this. Look at, I mean, we don't see them much anymore. What we see them is kids with,
myelodysplasia who have no infections,
Which
no
is the
reflux,
pressure.
but pressure.
No.
Now, the combination of pressure, reflux, and infection works together.
Right. But
But
even if they don't.
yeah, and we'll see kids with UPJ obstructions who start out with, you know, an okay kidney functionally by our scans, but deteriorate. No question. Now, we try to, those